Hi, Assalamu alaikum, my friends. Actually, I want to present one more very important topic in front of you people because you know that the we are doing preparing the two kind of the video library. One is in English and one in other in my native language Urdu. So this topic belongs to the in English version, and I want to present in front of you the Waddell's Triad. And Waddell's Triad, a lot of people know that it is very important topic to understand and to what we can say we should introduce in ourselves very popularly. So without wasting the time, I want to start the Waddell's Triad. Waddell's Triad represent a pediatric emergency, and the triad comprises of three distinct features seen on pediatric patients subject to the blunt force trauma, usually secondary to direct impact by a motor vehicle. They include ipsilateral femoral shaft fracture, ipsilateral intrathoracic or intra-abdominal injury, and contralateral head injury. The combination of these two injuries can lead to significant blood loss via internal hemorrhage. These activities outline the evaluation and the management of the patient presenting with Waddell's Triad and highlight the role of the interprofessional team in managing the patient with this condition. I am Dr. Muhammad Qazafi and you are watching Dr. Muhammad Qazafi Views. The objective of this presentation, the epidemiology of the Waddell's Triad you should know. I want to outline the necessary workup for evaluation of the patient presenting with the Waddell's Triad, explaining the importance of the pediatric trauma score for the assessment of the severity of injury in patient presenting with the Waddell's Triad. And I want to address the importance of coordinating among interprofessional team members to improve outcome for the patients presenting with Waddell's Triad. First of all, I want to introduce the Waddell's Triad like that. Waddell's Triad represent an emergency for pediatric patient due to high incidence of injuries associated with femur fracture, and the triad comprises of three distinct features seen in pediatric pedestrian patient with blunt force trauma, usually secondary to direct impact by a motor vehicle. They include ipsilateral femoral shaft fracture, ipsilateral intrathoracic and intra-abdominal injury, and the contralateral head injury. The combination of these three injuries can lead to significant blood loss via internal hemorrhage. Emergency medical services should transport these patients to the pediatric trauma center capable of treating this special patient population, and the children have lower mortality rate after severe blunt trauma when treated in designated pediatric trauma center or in hospital with pediatric intensive care unit are available. In this inquiry, the pedestrian absorb all the energy of this collision. The severity of injuries depend on the factors such as the speed of the vehicle, the weight of the pedestrian, and the frontal structure of the vehicle. So there is also the potential of severe hemorrhaging in the abdominal, and these patients should consequently have blood crossed and tied in case an emergent transfusion is necessary. Also, when Waddell's Triad is present, monitoring patient closely for hypotension and other signs of the shock of utmost importance. Regarding the etiology of the Waddell's Triad, Waddell's Triad occurred due to the blunt force trauma sustained secondary to direct pedestrian impact by a motor vehicle. Classically, there are three phases in the injury sustained by these patients. The impact of the bumper, followed by the impact of the windshield, hood, and finally the impact on the ground. The injuries of the pelvic limbs are due to the impact of the bumper. The thoracic and abdominal trauma result from the impact of the hood, windshield, and the head or cervical spine trauma result from hitting the ground. An individual who presents with Waddell's Triad should be treated with significantly injured with the potential for severe hemorrhage and subsequent hypovolemic shock. Regarding the epidemiology of this Waddell's Triad, according to the WHO, World Health Organization reports on the child injury prevention worldwide, unintentional injuries are the leading cause of the death in children between 10 to 20 years. In the United States, more than 12,000 children die each year secondary to unintentional injuries. Motor vehicle injuries are the leading cause each year. Roughly 10 million children are treated with United States Emergency Department for injury due to the falls, but motor vehicle injury rank among the top 15 causes of disability in children worldwide. History and the physical examination is very important, as in this Waddell's Triad, like it is important in every kind of injury we face or we are treating usually. The complete history and the physical examination is part of the secondary survey, which is done once the patient is stabilized. The patient's age for clinical coordination may preclude them from relaying detail of trauma, so physicians should seek information from a family members, other witness of the trauma, and EMS workers. The mnemonic AMPLE, A-M-P-L-E, I am repeating, A-M-P-L-E, can capture important information to obtain about the patient and the clinical scenario. So the mnemonic AMPLE, the ample of A with the allergies the patient has, we should know, and we have to ask as much as accurately. The M of the ample is medication of the patient should be on appropriately and immediately. The P of ample telling past medical history of the patient. The L of ample, last time the patient ate, what he ate last time. And the E of the ample, events related to the sustained trauma and any intervention by EMS. Healthcare professionals should seek a detailed mechanism of injury because important information can be gathered from even seemingly trivial statements. We have to give importance even the trivial statements because sometimes it's important, and if you know, it won't harm you, but if you don't know, then it may harm the patient. Waddell's Triad occur as a result of high injury impact. Therefore, a clinician's primary goal during the initial physical examination should be ruled out associated injuries and subsequently treated all injuries requiring emergency care when a child present with one or two signs of the triad after a motor vehicle injury. It is important to look for the third sign, which may present later. So, when a child presents with one or two signs of the triad after a motor vehicle injury, it is important to look for the third one. I am repeating this sentence because this triad is presented to you because it's had so much authenticity, and when the litigation will start, you can justify these things. Evaluation of the patient is the very, very important thing, because all the treatment and the management has been taken only after when you do the proper evaluation. The full workup includes the whole body CT scan, which can rapidly identify injuries to the brain, intracranial hemorrhage, chest, abdomen, and presence of any fracture. This is usually done as a part of the tertiary trauma survey, which follows the secondary survey of focus history and physical examination as a part of the tertiary survey. Laboratory and the radiological evaluation in the emergency setting have prognostic importance but be limiting. Examples include a lateral cervical spine radiograph, missing clinically significant injuries, and the hemoglobin and the hematocrit levels which have not yet equilibrated after the hemorrhage, and the abnormal liver function test which may be seen in abdominal trauma, but these patients usually go for CT scan and surgery immediately. So the priority of each and everything is highly, highly important. Because here the dilemma is little corrected for these kind of the Waddell triads, so we have to choose the proper things rather than wasting the time for unnecessary investigations or unnecessary things. In the same manner, these labs are not a standard procedure for every patient, which may slow down the triage process. So the clinical predictions of the doctor or the trauma surgeon or the pediatric trauma surgeon rule out the combine the history, the physical examination have been developed to identify those at low risk of injury and subsequent deterioration. In these patients specifically, the radiographic and the laboratory studies may not be necessary as we are thinking as usual, because this triad is not the usual. It's a proper kind of new understanding to treat the pediatric traumatic patients, especially secondary to the RTA. And as I mentioned, this is 10 million is a number, is some number in USA. And definitely if we check in other countries, definitely if they count it, definitely they find some number, and this some number is causing some problem to the patient. So the treatment and management, the initial management of the patient with the Waddell triad begins with the usual primary assessment or survey of the trauma. The primary survey addresses airway, breathing, circulation, neurological deficit, and the exposure of the patient and the control of the environment. So the key points here, such as the airway and cervical spine, you cannot separate from each other. Remember to check for the cervical spine injury while optimizing oxygenation and ventilation. The current standard is to immobilize the cervical, thoracic, and the lumbar spine in a natural position with the stiff collar. Head block is tape or cloth position across the forehead, torso, and the thigh, and the rigid backboard. These restrain the children and airway obstruction usually manifests as snoring, gargling, hoarseness, stridor, and the diminished breath sounds. So the airway obstruction can also result from fractures of the facial bone. Secretions such as the blood or the vomitus, crush injuries of the larynx, or the foreign body aspiration should be considered. If the healthcare professional needs to open the airway, a jaw thrust without head tilt is recommended. So this procedure minimizes cervical spine motions. Second key point is breathing. Breathing can be assessed by counting the respiratory rate, visualizing the chest wall motion for symmetry, expansion, accessory muscle use, and auscultating breathing sounds. In addition to observing for cyanosis, pulse oximetry monitoring is standard. If ventilation is inadequate, bag mask ventilation with 100% oxygen must be initiated immediately, followed by endotracheal intubation. Circulation, which is the third key point, and the circulation deal with the perfusion of the various body organs and identifying the signs of the poor perfusion or shock. The most common shock in trauma is hypovolemic shock and caused by hemorrhage. Signs include such as tachycardia, weak pulse, delayed capillary refill, cool, mottled, pale skin, and altered mental status. Loss of more than 40% of the blood volume causes severe hypotension that may become irreversible. Therefore, direct pressure should be applied to control external hemorrhage. 2 large bore IV should be inserted to maintain adequate hydration. Aggressive intravenous fluid resuscitation is crucial in early stage of shock to prevent further deterioration. An isotonic crystalloid solution such as lactated Ringer's injection or normal saline 20 ml per kilogram should be infused rapidly, so the serial hematocrit should be measured to ensure there is no acute bleeding. But if the patient remains in shock despite a fluid boluses, then 10 to 15 ml per kg of prosmatched packed red blood cells should be transfused. Or if you think there is an intrathoracic bleeding and you find there is an intrathoracic bleeding, then it's usually managed by placing a chest tube for drainage. Blood loss from a femur fracture can be massive and may require the multiple blood transfusion. Likewise, neurological deficit can be assessed by determining the level of consciousness, which is classified using the AVPU scoring system, such as the A for alertness. We have to check the alertness for neurological deficit. You have to remember AVPU. As I'm repeating, the AVPU is starting from the A, and A for alertness of the patient, how much he is alert. Then the V belongs to responsive to verbal command only. If you are giving some verbal command, how he or she responding to you. And then the P is for painful stimuli and how she or he is responding to you on painful stimuli. And the U is suggestive for unresponsiveness at all. In addition, a Glasgow Coma Scale score should be assigned to every patient with significant blood trauma, and this scale assists eye opening, motor, and the verbal responses. The GCS help categorize neurological disability, and the serial measurement can help identify improvement or deterioration over time. A child with severe neurological impairment, a GCS score of 8 or less, should be intubated immediately without wasting the time. Head injuries account for at least 75% of the pediatric blunt trauma death and are usually managed with supportive care, but one should always monitor for the child to development of elevated intracranial pressure due to an epidural or subdural hematomas. The signs of increased intracranial pressure include progressive neurological deterioration, and the transtentorial brain herniation must be treated immediately with the brief hyperventilation and with neurosurgical consultation in case emergency surgery is necessary. Exposure and environmental control likewise. We have to check upon arrival of the emergency room, all clothing should be removed to reveal any injury. Cutting is the quickest method and minimizing unnecessary patient's movement, so cutting the cloth is the best rather than removing the cloth or the dressing. Healthcare professionals should also remember that the children often can arrive hypothermic because of these higher body surface area to mass ratio. So the warning technique include the use of the radiant heat, heated blankets, and the intravenous fluid, which should be a little warm, can be administered. Overall, there is no symmetric treatment for the femur features in children. However, other factors should be considered. For example, the age of the child, the soft tissue injury, the type and the location of the fracture, the concomitant head, thoracic, and the abdominal trauma, and surgeon's expertise, and the family's psychosocial situation. Trauma scores provides an objective description of the patient's condition and help clinicians recognize the individual who have sustained the most severe injury and need the most immediate medical care. The pediatric trauma score, for example, can easily be applied for the Triad patient classification according to the severity of these particular patients at the scene of the injury and in the hospital. It also has multiple application, which includes prediction or prediction of chance of survival and degree of the central nervous system impairment. Here I want to mention some differential diagnosis regarding the Waddell's Triad. Waddell's Triad usually related to the road traffic accident, but if somebody muffled that road traffic accident, muffled the injury with the road traffic accident, and actually the patient has been abused or he got the abusive head trauma, then you have to check it. It could be differential diagnosis. Chest abdominal trauma should be in the differential diagnosis. Countercope head injuries should be in the differential diagnosis. Failure to recognize associated life-threatening injury should be in the differential diagnosis. Leg injury should be in the differential diagnosis because of any other reason. Physical child abuse should be in the differential diagnosis when you are considering the Waddell's Triad. It's very important in those countries where the litigation is so high regarding the medical and the medical principles, then we should take care of all these things. Whenever the children pedestrian are involved in the motor vehicle accident, it is important not to assume that they have only one organ injury. The full trauma team should be involved in the management of the children with Waddell's Triad. And it is very specific, this Waddell's Triad I present because the trauma team, the indication of the trauma team is so high in the Waddell's Triad. enhancing healthcare team outcome, how and when, and it should be considered from the hospital management or the ministry management or the director level management. But I want to tell here, like a serious multi-system trauma may cause significant long-term psychological and the social difficulties for the patient and their family. So the children are also at risk for the depressive symptoms and the post-traumatic stress disorder, psychological and the social support during the resuscitation period and afterward is very, very important for such patients. And the member of the resuscitation team should be made responsible for answering the family question and supporting them in the trauma room. And he should be available for the family separately other than the treating team. So this all from about the Waddell's Triad, what was in my mind, and I presented in front of you. I hope you would like that and appreciate me, and subscribe and share this video as much as possible. Thank you so much. We need your help and support all the time.